So again, she was treated with IVIP, cisplatin paclitaxel, and she has a complete response. CA-125 goes to 14.2, and she's without evidence of disease, which is obviously what we want for all our patients. So at this point, again, she's BRCA wild type, HRD positive based off the Myriad test. What's our decision tree? She can be observed, niraparib maintenance, Bev plus olaparib. And again, I would have to say this too. If you started them on Bev, and I think if you follow the guidelines, you could also, I mean, Ovarian was just presented. It's not labeled yet, but combination niraparib with bevacizumab and Ananova, as well as with Ovarian, I think is out there, and that may come later. But these are the treatment decisions that we can make at this point. And again, I think what are the recommended niraparib doses based off of body weight as well as platelet count. So, you know, you can see over there on the right, 49-year young patient, you know, had advanced stage ovarian cancer, germline tested. You know, to me, I wouldn't observe anybody. I personally think that HRD is predictive and prognostic. I know people will debate that for a long period of time, and I'm sure that will still be debating in a couple of years. But to me, I don't really observe anybody at this point, whether they're HR proficient, HRD negative, I would treat. So if I started them on Bev, I would probably go with bevacizumab and olaparib at this point. I do love the PFS, the absolute PFS change with bevacizumab and olaparib versus Bev alone. I thought it was a very interesting presentation this last SGO where they looked at PAL and solo and PAL patients to the solo patients. And, you know, again, I need to wait for that paper to really understand the statistics, but I was fascinated by that, by the presentation, and saw that you probably are potentially getting an additive effect even in the BRCA mutation patient. But to me, I think that those are all three observations. My weight would be, you know, bevacizumab plus olaparib, probably number one. Number two would be switch from somebody off bevacizumab to niraparib alone, and the observation would be least the lowest choice at this point. I also think that it's nice that we have all these new approvals, because if you're going through treating somebody and they have a massive PE and you can't give them Avastin or don't feel comfortable with Avastin, you could use single agent olaparib. Some people would do that, but if you go by NCCN, you could switch over to niraparib. And if somebody's having really bad thrombocytopenia, don't feel they can tolerate niraparib, then you have a combination of olaparib bevacizumab. So we've been doing this in our group since ESMO, and have attached the papers, and have really had quite good success getting both the niraparib approved in this instance, as well as bevacizumab and olaparib approved in this instance. So to me, I think it was a great presentations at ESMO, and I think the data is very compelling. And so I just think that observation is an excellent scientific question, but as a clinician, I want to treat the patient, so I would use some type of maintenance therapy. And I'm curious to hear what you guys think.